Welcome everyone and good afternoon. My name is Gergely Kollányi and let me talk to you about my project and the progress of the last 12 months. My PhD title is ERCP-guided pancreatic procedures. My vision is to give patients comfort and the best possible care, and I want to achieve that by improving the safety and efficacy of endoscopic procedures. I'm a first year PhD student and a gastroenterology resident in St. Imre Hospital. Currently I'm working on 3 projects, but due to the shortage of time, I will focus only the first 2 of them today, which are closely related to ERCP and pancreatic diseases. The first one is investigating the accuracy and safety of ERCP-guided biliary and pancreatic ductal tissue sampling in pancreatic cancer. Pancreatic cancer is one of the most lethal cancer types in the world, but this is not the only problem with this disease. There's an issue with diagnostics as well, because most of these patients get diagnosed in a late phase when only palliative care is available, so early diagnosis is crucial. This disease often presents as a biliary stricture or a so-called double duct sign, and in these cases the guidelines suggest intervention, ERCP-guided intervention, to be taken, and during the intervention to do brush cytology. But the problem is that brush cytology has a low sensitivity, and the literature suggests that taking it from the pancreatic duct, we could increase this sensitivity. So with this study, our aim is to compare the 2 brush cytology sites, biliary and pancreatic ductal brushing, for diagnosing pancreatic cancer. Our clinical question is that, is pancreatic duct tissue sampling superior to biliary sampling in the diagnosis of pancreatic cancer when we evaluate biliary strictures? We have 3 index tests, and we want to compare them to the gold standard, which is histology. And we are also interested in complication rates. We hypothesize that pancreatic duct tissue sampling is superior, and if this is true, then the patients may receive the diagnosis faster, and they may need less minimally invasive procedures. You can see here the flow chart of the selection process, and as you can see, we reduced the number of the eligible articles to 81. We have some finished analyses, but the comparative ones are still ongoing. So let me introduce you the already finished ones. The first one is, as you can see here, the pancreatic and bile duct brush cytology pooled sensitivities. Sensitivity is one of the key indicators of a diagnostic test. You can calculate it by dividing the true positive cases by all the disease patient numbers. It is expressed as a proportions ranging from 0 to 1, where 1 indicates when all the disease patients were diagnosed correctly by the index test. On the left side, you can see the pancreatic duct brush cytologies. We included 16 articles with over 500 patients, and these are mostly retrospective or prospective cohort studies. You can see that the heterogeneity is moderate, which can be explained by the different indication of the procedures, and also by the lack of generalized cytological criteria. The pooled sensitivity is 0.59 in the pancreatic duct brush cytology group, and for the bile duct cytology group it was 0.4. The heterogeneity was also quite, it was also moderate in this case with similar reasons. So these are not comparative results. therefore, I don't want to draw any conclusion yet. In the next slide, you can see the post-ERCP pancreatitis rate of these two procedures. This is one of the most common complications of ERCP, and it is also expressed as a proportion ranging from 0 to 1, and it is acceptable under 0.07 or 0.1. And as you can see, both groups yielded 0.03 proportion, which means that 3% of these patients who underwent these procedures developed post-ERCP pancreatitis. This is the current progress of our project. We are still waiting for some of the comparative results, but in the meantime, we are started to write the manuscript as well. My second project is about investigating the efficacy and safety of transpapillary drainage of pancreatic fluid collections. As you may know, pancreatic fluid collections are one of the major complications of pancreatitis, and it is divided into 4 major groups by the revised ATLETNEC classification, and in this study we are focusing 2 of them, the 2 late phase complications, which are pancreatic pseudocysts and walled off pancreatic necrosis. Pancreatic pseudocysts can reach up to 40% in chronic pancreatitis, which is quite high, and the majority won't resolve spontaneously, requiring intervention because of the complications. The most common intervention is endoscopic. This is the most accepted route, endoscopic intervention, which could be either transmural or transpapillary route. The first is US-guided, the second one is ERCP-guided. However, transpapillary drainage is not widely used or recommended, but it has a high success rate. It has a really narrow indication range. So with our study, we want to compare the transpapillary drainage to the other type of endoscopic interventions for these fluid collections. Our clinical question would be, what is the safety and efficacy of transpapillary drainage of pancreatic fluid collections compared to the transmural or the combined drainage? The population would be adults and with pseudocysts or walled off necrosis, and we are mainly interested in success rate, complication rate, and recurrence rate. We hypothesize that the transpapillary or the combined route is more effective than the transmural alone. If this is true, then we can fine-tune the recommendations for these interventions, which can mean that the patients will have reduced recurrence rate, reduced complication rate, and maybe improved success rate. This was the preliminary research key that we used with 3 domains. The first referring to the ERCP procedure, the second for the disease, and the third one for the specific intervention process. And we conducted the search in 3 databases. It yielded over 1,500 results. So summarizing, I have 3 ongoing projects, which I plan to finish the first, well, not in September, but after September if I get the results. So thank you for your attention, and I brought this quote from Sir William Osler: "He who studies medicine without books sails an uncharted sea, but he who studies medicine without patients does not go to sea at all." Thank you.
Thank you very much. Any questions? your hypothesis in the first project was that drainage through the transpapillary drainage would be more effective than the transmural. Why would you say that? What was the background of this?
In the second project.
Sorry, second.
So our hypothesis is that transmural or the combined drainage is more effective. Well, transpapillary drainage is more effective, I think, in selected cases based on the studies I found because it can bridge the disruption of the pancreatic duct, which can lead to less complication like fistule formation or bleeding, etc.
Yeah, fistula formation is basically not a real concern if you are doing a transmural type of US-guided drainage, because it is fistulizing into the GI tract. Fistula is causing problem when it goes elsewhere into the pleural cavity or in the abdominal cavity. That might be a real problem.
It is compared to, it's not compared to the transmural, but the transcutaneous. Yeah.
I have a short question regarding the second project. What we do or what we see in the everyday routine, we decided for a transpapillar drainage based on the location of the cyst. That means when the cyst is very close to the papilla, based on the MDT and the discussions, we try to do a transpapillary drainage. And after that, when the location of the cyst is the second part of the pancreas, tail, or the body, after that we start to thinking about the US-guided and so on. My question is, or my short comment, did you find any relevant data regarding the locations of this cyst?
Yes, thank you for your question. Most of the data suggest to do the transpapillary drainage when it is further away. If I remember correctly, more than 5 centimeters away from the papilla, or if it's further away from any possible route for the US guided needle to penetrate.